Okay, guys, so I am recording now, and so I'm gonna go ahead and start the slideshow. And because I'm gonna put this on my YouTube, I do need to just point out that this book is from Jones and Bartlett Learning LLC, just citing where I'm getting this information. All right, so we stopped at parenteral administration. We were just about to get into parenteral administration. So as we talked about last time, parenteral administration is used when patients cannot take anything by mouth or if the drug is ineffective orally, right? So that's when we're getting into the injections as well as intravenous route, right? And other routes other than oral, okay? Parenteral administration has a rapid effect. Once you give parenteral administration, it cannot be retrieved, right? Because we're giving it via injection, via intravenous, right? Or um, rectally, vaginally, which we'll talk about later. All right, so it's the most effective, but it's also the most hazardous as well. When we give an injections, when we give a medication, period, we always want to, like we said last week, we want to check and recheck before we give a medication, right? We're going to verify the patient, we're going to verify the medication, right? Because once we give it, we cannot retrieve it. So we have to make sure we are giving it to the right patient. You guys remember those 7 rights, right? Make sure you study those because you may pop up with the pop quiz on that. So make sure you guys are studying those 7 rights of administration, okay? A possible injection site infection. I see somebody just asked a question. Let me see. Okay, somebody said yes. Okay, gotcha. Alrighty. So this is the equipment for injection. So we have ampoules, vials, and we have cartridges. Okay. So these are ampoules. Okay. Now ampoules, those are small glass containers they're glass. So we have to be careful when we're dealing with those. Those you break at the neck. You guys probably can't see this, but there's a little black line here at the neck of it. So what we would do, we would take a gauze to hold it so we don't cut ourselves. Just take a gauze and then just pop it open right at the neck. I'll show you guys some examples if we have them in the classroom. And then these are vials. So vials can be multi-dose and they can be single dose. So this is an example of a single dose vial. That just means that we just want to use it one time. The amount of medication that we need to administer is the amount of medication that's in the vial. And then you have multiple dose. So multiple dose vials, that just means that we can get multiple doses from it, right? It'll likely be left in the refrigerator or cabinet, depending on how it needs to be stored. One thing I want to mention too, when we are using multiple dose vials, we want to clean the top of the vial, the cap, not the cap. I'm sorry, the cap is the top, but we want to clean the rubber part of the vial before we drop a medication. And I'll show you guys this when we get back in class. But you want to clean it off each time before you draw it up when you're using a multi-dose vial. Now, for me, because it's so routine cleaning off the top of the vial, even with the single dose, I still go ahead and clean the top of the vial. It's just it's better to clean it off and you don't need to versus not cleaning it and you should have. So it's just when I open a new vial, I clean it as well. So you want to get into the habit of cleaning off the top of your vial, okay? And again, the top of the vial, when you take the cap off, is rubber. It allows for easy insertion of the needle to draw up your medications, okay? Now, these are pre-filled cartridges and holders, and we'll talk about that later. All right, so you got your vials and you got your ampoules. All right, so vials, they can be either liquid or powder. If it's powder, you will have to add a diluent, meaning you'll have to dilute it, okay? Now, um, in my experience, I've only had to do this with a few different medications. One of them being when I worked in pediatrics, one of the pediatric vaccines they get is Hemophilus influenza. So that's one of the vaccines that we definitely had to reconstitute. So if you do have to do that, you just simply again using a multi-dose vial, you want to clean it off, and then you want to write the date of the reconstitution, your initials, okay, and then the diluent that you use. All right. And I don't, do we have any of those in the classroom? I'm not sure if we have any of those in the classroom. If we do, I'll show you. But anyway, so it would be the same way you draw up any other medication, liquid medication. It's just that with this one, you do have to add the diluent first and then draw it up. And like I said, I've only had to do that with a couple different medications, definitely that Hib vaccine. All right, and so this is just going more into detail. So when you're reconstituting a dry medication, you're going to draw up the diluent. So you have to draw the diluent up, and then you have to add it to the powder, to the vial with the powder. You're going to roll it between the palms of your hands to dissolve the medication completely. Don't shake it because it may cause some unnecessary bubbles. So we roll it in our hand. Once it's dissolved, we're going to calculate the dose based on the amount of diluent added to the powder. All right. Now it's going to vary from manufacturer to manufacturer, so you'll know exactly how to reconstitute the medication that you're drawing up. Always check the vial label or manufacturer's instructions before adding the diluent to determine the resultant dosage. All right, so these are pre-filled cartridges, okay? Now, and I will tell you this, especially if you guys are working in pediatrics, when in pediatrics, you give more injections than any other. Well, I don't want to say that, but I know in pediatrics, you're going to be giving injections pretty much all day because you're going to get a lot of children that are coming in for their well child visits. So when these pre-filled medication cartridges, I'm telling you guys, these pre-filled syringes are literally like heaven because you don't have to sit down and draw up the medication each time. Some of them already come with a needle. Some of them you just have to add the needle, but regardless, pre-filled syringes, when you guys get out there, you're going to see what I mean. They are literally a medical assistant's or a nurse's dream because everything is already drawn up for you. Did somebody unmute? See, I hear something. Okay, I was just getting some feedback. So those are pre-filled syringes again, or cartridges. All right, so let's talk about the parts of a needle. So we got needles and syringes, right? So a lot of needles, they already come already attached to the syringe, right? In some instances, the syringe and the needle will be separate, and we have to assemble it ourselves. But let's talk about the parts of a needle. So we got your plunger here. This is what we use to actually draw up the medication and inject the medication, right? This is your barrel. This is how we're going to measure how much medication we're using, right? We're drawing up, right? And administering. And this is your needle here, the needle here, and this is your hilt/hub, your hilt hub. All right, so you got the shaft of the needle, okay, which is the length of the needle. That's the shaft of the needle. So when we're talking about inches, it's measuring the shaft, okay? Then you have your bevel. You guys know the bevel is the opening, right? And then the lumen, that's that hollow area inside of the bevel, okay? Now most syringes are going to be 1 or 3 mLs. All right, 1 ml or 3 mLs. Now, if we're using a syringe that's greater than 5 mLs, usually for irrigation, like if we're doing the irrigation of the eye or ear. And then the flange. So just like you guys know how we were doing, venipuncture and the Vacutainer holder had a flange. Now this is the flange of the needle of the syringe. So this is the flange right here. It's the flange. All right. So different types of syringes used. Now, insulin, you're going to know an insulin syringe because the top is going to be orange. Okay. Now, when we're talking about insulin, we're drawing it up in units as opposed to, we're not going to say ml. Syringe, insulin is drawn up in units versus milliliters. Now, you might hear me say 3 cc or 3 ml. 3 cubic centimeters, it's the same thing. Okay, so remember I wrote it on the board the other day. cc and ml, they're equivalent. So if your physician says I need 1 cc of a medication, they're talking about 1 ml. So it's the same thing. Okay, so we got the 10 ml syringe here, then we got the 3 ml, and then we got the 1 ml, and this is an insulin syringe, and this is a low dose insulin syringe. All right, so I'm not going to read this word for word, but you guys can take a screenshot of this because you do need to know your needle sizes, the gauge size, as well as the length for each injection, okay? So I'll just kind of throw, like for an example, intramuscular injection. The length for intramuscular injection can range from 1 to 1.5. okay, depending on the size of the patient and the fat to muscle ratio. And the needle gauge can vary from 20 to 25. It's very important to know the inches, okay, as well as the gauge size that you need, because let's look at subcutaneous. Subcutaneous injections, we can use a 23 to 25. However, the inches can range from 5/8 to a half an inch. And it matters because if I were to ask you, hey, what injection can we give with a 25 gauge 1 inch, right? We can do an intramuscular with a 25 gauge 1 inch. But if I say, what injection do we give with a 25 gauge 5/8 inch? Okay. So even though the gauge size is the same, the length of the needle matters. Okay. Because that 5/8 inch needle is not going to be long enough to reach the patient's muscle for an intramuscular injection. Okay. So it's very important for you guys to know these needle sizes. Okay. And remember, the higher the number, the smaller the needle, right? So this 18 gauge needle is much larger than the 30 gauge needle. Okay. All right. So your package, your needle package will always tell you what size it is. And let's look at this. So this is a 25 gauge and the 23 gauge, both 1 inches, but different gauge sizes. Look at the difference in the needle size. Okay. Now let's look at the 22 gauge, 1.5 inch. Look at that length compared to the 1 inch, right? You see how it's longer, right? And then look at the 18 gauge needle, 1 inch. Okay, so look at your different needle sizes. All right, and then again, this is a picture of the needle and the hub. Also, one thing I want to mention is that your needles, they will be color coded. You'll notice. All right. All right, so again, the needle components, you got the hub, the shaft, and the bevel. Now, intradermal is right up under the skin, right? So those are shorter needles, whereas intramuscular are long, right? Subcutaneous has a small gauge, intramuscular has a larger gauge, okay? And again, the packaging is color coded. So intradermal injections, that's the first injection we're going to talk about. We're going to use a TB syringe for that, all right? And it ranges from 25 to 27, from 3/8 to 5/8 inch. All right. Insulin syringes is strictly for insulin. All right, strictly for insulin. All right. So what was the difference between the ampoules and the vials? We said that the ampoules, they're both medication containers, but the ampoule is a glass container with a narrow neck. We have to break it to obtain the medication. The vial is a glass or plastic container sealed with a rubber stopper. They may contain liquid form or dry form. And if they're dry, again, we have to reconstitute it by adding the diluent. All right, now let's look at this. Now, this, you see this right here, and this is showing us the different angles that we have to administer. Sorry, guys, this is my alarm. I'm sorry. Let me stop that. And so this right here, this picture shows us why it's so important to go at the correct angle. Remember when we talked about the right technique, when we were talking about the 7 rights of medication administration? It is very important that we go the correct angle, because look at that. Notice how intramuscular is given at a 90-degree angle, right? Why are we giving it a 90-degree angle? Because that medication has to reach the muscle. If we're given a medication that is to be given intramuscularly and we give it at the incorrect angle, let's just say we give it at a 45-degree angle, we're not in the muscle. So that means that that patient did not get that medication, right? So we have to go at the right angle. One of the things with intramuscular, they get scared to go in because they feel like they're hurting the patient. But think about it. If it's not reaching a muscle, it's not being given. Okay, so this is intramuscular, given at a 90-degree angle. Okay, now sub-Q is given at a 45-degree angle. This is the subcutaneous tissue. The exception is when we're given insulin. Okay, insulin we're given at a 90-degree angle. Okay, so those insulin needles, when we look at them, when we get back into the classroom, you'll see how small those insulin needles are. So we can give insulin at a 90-degree angle and still be in the subcutaneous tissue. Okay. So again, intramuscular is given 90 degrees, right? Subcutaneous injections is given 45 degrees, okay? Think of a side of a triangle. The exception to that is when we're given insulin, that's given at a 90-degree angle. And then we have the intradermal injection that's given 15 degrees. So anywhere from 5 to 15 degrees for the intradermal injection, okay? And notice it's right up under the skin in the dermis, right? So intradermal injection, again, we're going to start with that one. 5 to 15 degree angle can be given in the forearm or back. Now, when we're given the intradermal injection, now you'll hear me say TB test and PPD interchangeably. I'm just referring to the TB test, okay? When I say PPD or TB test, all right? And each of these injections, I do have videos for you guys. It is in your resources folder. So you'll be able to see an example of each one. But when we give the TB test, right, we're giving it in the forearm, and I'll show you guys exactly well, you'll see on the video. Now, tuberculin time test and the Mantoux test, they're both PPD tests. This is the older one, the way we used to get it. I don't know if you guys are well, I know some of you are probably not old enough to have had the tuberculin time test. But it was different. It was like a quick, it was much quicker. It was like a prick, and they had multiple needles. It was multiple needles on that one needle. And then the Mantoux test is what we give now. All right. Positive test has an end duration. Intradermal is also used for allergy testing as well in the forearm or even the back. So both the time test and the Mantoux test has to be given within 48 to 72 hours. I'm sure you guys have had a TB test before and you had to go back and have it read between 48 to 72 hours. So it's very important when you give your TB test to let your patient know to come back within 48 to 72 hours, not within, to end 48 to 72 hours. Because if we say within, they may think, within can be any time between, any time prior to 48 hours, but it has to be 48 to 72 hours, okay? Not in 24 hours, not less than 48 hours, but 48 to 72 hours, okay? Now, the positive test, if a patient has a positive test, which you guys may have to read the TB test as well, depending on where you work. Where I've worked, it was more so the RN with the RN or the LPN would read the TB test when they came back, but it's within our scope to read a TB test. So if it's larger than 10 millimeters, it can indicate a positive test. Now, if a patient has a positive test, it doesn't necessarily mean they have tuberculosis. They may have just been exposed to it. And the thing about the TB test, once it's positive, it's going to always be positive. So going forward, they may have to get, like most patients who test positive, they get like a chest x-ray every 5 years just to make sure they don't have it. Because once you're positive, you're going to continue to be positive. Okay, so this is the time test. So notice that needle within this needle, there's literally within this lancet, there's literally multiple needles there, and it will be like a quick prick. And then same thing, you come back in 2 to 3 days to have it read, and they would circle it with a smiley face. And if you're working in pediatrics, you may want to, do something for the little for the little one, just to make them happy about it. And we also want to make sure we tell our patients not to rub it or scratch it. All right, so subcutaneous. So subcutaneous is given in the fatty layer, in the adipose tissue, right? Okay, below the skin, 45-degree angle. Remember we said the the exception is insulin, that's given at 90-degree angle. Subcutaneous can be given in the upper arm, the thigh, the back, or abdomen. It's used for drugs that should absorb slowly. Now, patients who are on insulin, they do have to give their own injections at home, insulin injections at home. So they will alternate between their thigh, and their abdomen most of the time. And so, and in insulin patients, they get a chart because they can build scar tissue around the site. So they'll get a chart, and that way they can make a note. Every time they give an injection, they can make a note of where they gave it so they can give it in a different site the next time. And that just made me think that is a test question, an NHA test question. They ask about what a patient should do when they take insulin, and they should alternate the site each time to avoid building scar tissue. All right, intramuscular injection, we said 90-degree angle, right? The muscle sites, we have the deltoid, dorsogluteal, ventrogluteal, and the vastus lateralis. In some cases, it may be given in the rectus femoris, only if the other sites are not available or it can't be used for some reason. Now, intramuscular injections is fairly rapid, okay? So those are absorbed very, very quickly. All right, so no more than 1 ml should be injected into the deltoid muscle and no more than 3 into the other muscles of an adult. Now, children younger than 2 years old should never receive the gluteal injection. That muscle is not well developed until the child is walking. The muscle chosen for the injection depends on the preference of the medical assistant, the patient, and the amount of medication to be administered. Now, even though we primarily give the intramuscular injection in the deltoid on an adult, I have had an adult that was so afraid that she asked to give it in her thigh. So, her vastus lateralis muscle. So it is possible that an adult may request that because she was afraid of needles and she did not want it in her arm. Now, this is the injection site for the deltoid muscle, and I believe there's a video on that I have posted for you guys as well, so you'll see that. Now this is the gluteal injection. Now, one thing about giving sites in the doing the glute injection, you do have to be careful for the sciatic nerve, okay? Because that can be damaged. Now, one of the mistakes that I've seen people make when they're giving a glute injection is being down too far. Okay, you're on the gluteus medius, right? And we're not down on the buttock. So that's one of the mistakes I see people make, is giving injections down on the buttock. That's putting you more at risk of hitting that sciatic nerve. So I have a video. I don't know if I posted it for you guys, but I can post it. But I do have a video that I normally show to give an example of the glute injection. So this is the dorsogluteal, and this is the ventrogluteal site. All right, vastus lateralis here. So we're giving on the vastus lateralis muscle here. That's the outer thigh, right? And then the rectus femoris here, only when other sites are contraindicated or should not be used. All right, so then we have Z-track method of intramuscular injections. This is another injection that's within our scope, but the RN or LPN, if a patient needed a Z-track injection, the RN and the LPN would get it. And that's why I always say some things are going to depend on where you work, because there's some things that's just outside of our scope, but then there's some things that's just depending on where you work, they would have the one of the nurses do it as opposed to the medical assistant doing it. All right, so PAM attended an accredited medical assistant program and was taught to administer a variety of injection methods. The types of injections and possible sites for each type are intradermal, subcutaneous, and intramuscular. Intradermal injections include the anterior forearm and the back. Sub-Q include the upper arm, thigh, back, and abdomen. And then intramuscular include the deltoid, ventrogluteal, and vastus lateralis. All right, now other medication routes. I just mentioned it briefly. We have rectal administration. And then we have for suppositories or enemas. And then we have vaginal administration. So creams, tablets, dishes, and suppositories. Mostly for local effect, meaning that that is the area that's being affected and that is the area that we are treating. All right, so then we have transdermal administration, like a patch, right? Those are slow and steady. Okay, slow, steady delivery of a drug. That's the slowest route. So the slowest route is going to be transdermally. Okay, so that's like your creams and lotions and ointments. Okay, and your patches. Inhalation. The drug is administered via the lungs. Okay, now you may have to give your patient a nebulizer treatment, right? Some patients, they have actually nebulizers at home where they have to give themselves treatment. So it's administered through the lungs. How are medications given by the inhalation route absorbed? Medication administered through the inhalation route will be absorbed through the alveolar walls into the capillaries in the lungs. All right, and then this is intravenous equipment. Now, again, um, intravenous medications. One thing that I do know that laws can vary by state. So there may be some states, I don't want to say what state or which state, because there may be some states that allow medical assistance to start an IV line. Here, it is outside of our scope. Okay. So although we know IVs are outside of our scope as medical assistance, here in some states it may be allowed. That's why it's so important to know your state laws and what you can do and what you can't do within your state. All right, so this is the last of the slides. I'm going to go ahead and start recording here and stop sharing my screen. Alrighty, guys, so this is the end of the lesson. I was doing this lesson with my students. This is actually a continuation from a lesson we had already started last week and didn't finish. And I just decided to upload it just in case anybody else can benefit from it. And as I always say with these lectures and the clinical videos that I do, these are videos that I am doing for my students. These are videos of lessons that I do with my students. So if you ever have any further questions and need to verify anything, you can definitely make sure you do that with your instructor, okay? Any general questions, of course, you can always feel free to ask those down below or email me. That'll be in the description box as well. I hope that this video was helpful. Thank you for visiting my channel. Be blessed.